Uh, so the topic of discussion today is the sudden evaluation of shortness of breath in the ICU. So more important as we go on, because most of the things are known, but then again it is like, how do we get it in the nick of the time? So every time it might not be the same lock doesn't open by this, the multiple locks are not opened by a same key. So in that way, breathlessness in ICU has a very varied presentations in a different set of patients, because in ICU we get always a different set of patients. So more important is to consider the fact, the surrounding, the history, and presence of mind, which leads us to the diagnosis. It could be a simpler thing to a complicated thing. We'll just run through few of the things. So the basic structure of the discussion today is to focus on the normal anatomy and the physiology of breathing, then coming to the few of the conditions, acute conditions that leads to shortness of breath and that require immediate attention. And then we'll have a question and answer session just to get a better understanding of the subject. The idea here is to give you a better, brief, concise understanding of the shortness of breath, because it itself is in a task to complete it in this 45 minutes. But more or less after this brief discussion what we have today, probably we will be able to settle most of the things, if not all the things. So basically, when we talk about shortness of breath, or basically difficulty in breathing, or whatever abnormality in breathing, what we have to understand is the basic muscles of the breathing. There is an inspiration and expiration. So the primary inspiratory muscle is the diaphragm as well as the external intercostal, whereas normal expiration is a passive process. So by the elastic recoil of the lungs and the other physiological things, the expiration usually happens at rest. Sometimes when you require to do a force expiration or during exercise and all, there might be some other muscles that might actually help in expiration also, like the internal intercostals and the subcostals and the abdominal muscles. So if you can see here, the basic principal muscle of the respiration is the diaphragm and the external intercostal. Whereas if you actually, when you go exertional thing where you have to actively expire, okay, so that times, you know, a part of the internal intercostal and the ribs and the other muscles will take into action. Now, what is more important for us to understand, what are these accessory muscles of breathing? So why is it important? This is the physiological muscles of breathing. This is the accessory muscle of breathing. So whenever a patient is using his accessory muscles in the act of respiration, that means there is a difficulty in his respiration which needs to be evaluated. So the sternocleidomastoid, the scalene muscle, and the pectoralis minor are basically the accessory muscles which are used for breathing. Right. So whenever you see a patient using a shoulder, neck, or other accessory muscles, that's an indication probably that this patient is having some difficulty in breathing and needs appropriate evaluation. Right. So this is the pictorial view. So coming to the basic definition of a few terms to understand when we try to communicate in the ICU to our team and other colleagues also. So basically, rapid and shallow breathing is called tachypnea, whereas hyperventilation is just rapid breathing but not shallow. It would be deep. So both can be a basic cause, can be a result of accumulation of carbon dioxide in the bloodstream. Orthopnea usually happens in the cardiac cases where there is a severe LV dysfunction, where the patient have the dyspnea or difficulty in breathing at rest, even on the lying down or supine posture. Whereas platypnea is a one shortness of breath condition which is relieved when lying down, but worsens up when sitting upright, right? Usually seen in patient with liver disorders. So now when basically we go into ICU, you always have, it's like an open book or supermarket type where you have to fit in your diagnosis into the clinical presentation, signs and symptoms, what you see from the patient at that particular point of time with a particular background. So variedly, if it divide the causes of difficulty in breathing, it could be cardiac, lung, CNS, metabolic, anaphylaxis, and psychiatric. Now this is just a umbrella where we can just classify them. There may be a lot of other things also, but more or less, most of the causes fit into these subheadings. So when we talk about CNS, especially, there could be anything that can cause a respiratory center depression due to any drug overdose or a mixed edema coma that can happen. Patient may have spinal cord disorders where patient may have a RTA spinal cord injury at upper cervical level. So there, or the patient may have amyotrophic lateral sclerosis or a Guillain-Barré, an ascending type of palsy, where patient might come with only paresis or paraplegia. Gradually, it keeps ascending, and the discomfort starts. So probably then we have to intervene accordingly. And then we can also have the respiratory thing, that is the myasthenia, autoimmune condition, polymyositis, or hypophosphatemia. And sometimes muscle fatigue also will come to that topic. And sometimes the basic muscle wall itself or the chest wall itself will become very stiff and the compliance is bad, like patient having multiple rib fractures, that is a flail chest, where the synchrony is gone and the dynamics of breathing is altered, or patient is a post-op case of thoracoplasty, or patient is a severe ankylosing spondylitis case where the chest walls and the muscles are all rigid and stiff, wherein the compliance is decreased. Sometimes you may have a restrictive pleuritis or a massive effusion, and sometimes it could be a simple case of a stenosis, vocal cord tumor. And very interesting, most of the time, sometimes in ICU, when we cater to the elderly patients, or sometimes there could be a dentures that might actually get obstructed. So again, applying more presence of mind and trying to rule out the local causes and more common causes would help us to do the needful. So as we come to the differential diagnosis, as we were talking, in the pulmonary, we may have different conditions like pneumonia, for example. Now, we'll talk about each condition slowly, right? And then cardiac and the miscellaneous. So most common nowadays, as you might be seeing, any young, usually the young people, 30 or late 30s or the early 40s, most of them having sudden myocardial infarction and unfortunately succumbing to it. See, that this is one of the things now is any patient who is under stress, there is a high chance of any active stroke episodes that could be a CNS or a cardiac. Now, most common is suddenly when there is a mismatch in the supply and demand, you get a myocardial infarction. So typically in ICU, if the patient is not on any sedation, is not on ventilator, is a conscious patient, not altered sensorium, probably he may have those symptoms like chest pain, sweating, discomfort, or like stabbing pain, some tightness in the chest. In a patient who is having an active cardiac history or multiple comorbids, then you see the blood pressure, the vitals, you rule out the anxiety and the gastric APD part, then you take out the ECG, then the drop by. See, the idea is the sequence of it that is more important in building up the case. So once a patient has it, then most important in such cases as an immediate responder in the ICU is to calm the patient, call for help, appropriately connect oxygen so that the supply demand mismatch is reduced. So you take care of that. Probably you give the blood thinners, depending on the BP, you control the blood pressure until the time the appropriate help arrives, then further evaluating by echo, tropi and other things, and then finally doing the definitive care. Now, this is one common things now with the incidence of transplants getting more and more increased. A lot of people, especially CKD, coming during pre-op or suddenly being rushed to the ICU, or post-transplant kit is not working all. So there may be a flash pulmonary edema or exacerbation of a pre-existing condition, or sometimes a patient may develop a myocardial infarction as a reaction, he may develop a pulmonary edema. So there can be a combination of all those things. So again, in such situations like pulmonary edema, if you see a person who is struggling to breathe, there is crypts all over the lungs, BP is stable. So probably you connect him on oxygen, preferably if not maintaining with oxygen, you can also try a resort of NIV if he's conscious. Then if the BP is more, probably you can give a diuretic. If the BP is less, then you'll have to be more cautious. Take the team lead into the confidence and accordingly treat. And finally, settle the other parameters and try to evaluate the cause of why the patient has learned. Now here the important thing is understand in pulmonary edema, if the patient is not consciousness, then probably straightforward invasive intubation and ventilation will be the choice of treatment. And if the patient is conscious, so NIV. Always have to understand whenever we try to initiate NIV in a patient in ICU, always the crash cart for intubation has to be ready. And there should be a vigilant monitor from at least one person of the team. Anyone, the nurse or the duty doctor or the part of the critical care or any consultant, one person should be watchful in such cases. Anytime they can actually crash. Then more common thing with the winter just settling down and the summer starting, so probably the load of pneumonias will come down. But people with asthma, COPD, they might land up, they might have some other acute condition, and then they have an exacerbation of their lung issues with the onset of the disease or other things. So this is again most common thing. So when there is a history of asthma or emphysema or COPD or chronic smoker, so they might get exacerbated again, very easily diagnosed. Probably the only thing here you have to understand, if it's a COPD case, okay, so patient will have a history. So good NIV with nebulizations should help your patient to settle down till the time your consultant or any other appropriate help arrives. Only thing I would like to say here, a patient with exacerbation of asthma, if he's looking very silent, that means it's a difficult case where he's probably not breathing or is in the imminent signs of respiratory failure, which might require early intervention so that we do not get into any unforeseen complication of morbidity and mortality. So just assuming that the patient is now relaxed, acute asthmatic exacerbation of asthma is a tricky situation. Probably more watchful eyes will save us a day. Right, as we're saying, COPD exacerbation, you might see a pursed lips, patient struggling to breathe. There might be some peripheral cyanosis, bounding pulse. So these are all the corroborative signs that you might actually find in such patients. So probably putting him on an appropriate NIV with a nebulization with a dose of steroid plus or minus should help you for the initial treatment. Later on treatment, anyhow, as we said, the consultant of the team will arrive and accordingly take it over. Now, this is one thing very unpredictable in any situation, not only in the ICU, but probably in the ICU, we might face it much more often, is an embolic episode. Say, for example, patient is in surgical ICU, post hip replacement, okay, or patient had a polytrauma, he's on the bed for a longer time, he's not moving, or patient is on ventilator for a longer time, long bone fractures, you may have a fat embolism. So all these things, usually they all develop suddenly. Suddenly a patient might actually, whenever the embolus, the clot dislodges from the and forms an embolism, probably it might land up into your pulmonary vessels and cause an acute pulmonary crisis that could actually again lead it to sudden onset of chest pain, difficulty in breathing, patient have cough, and then accordingly then you'll have the criteria for embolism. But here again, more important thing is to assert the consciousness of the patient, give the oxygen to the patient, maintain the hemodynamics, and more important is, as usual, anytime you call for help for your team so that you can handle this case better. But again, pulmonary embolism more or less is a clinical diagnosis. It's confirmed by your radiological diagnosis, but these are all presentations are very subtle. So an alert team member is what is required for the hour to diagnose a patient with pulmonary embolism, that to at early stage, so that we can probably reverse it. Usually, if diagnosed early and treated aggressively, the recovery rate is actually good. Once MOD set in or patient goes into refractory hypoxia and other things, probably the outcome may not be that positive. Then coming to pneumonia, all the world in the last couple of years has been dreading with this word. Not exactly pneumonia, but COVID pneumonia. But now I think a lot of people are aware of what is exactly the pneumonia, and a lot of medical staff also. But again, that's the disadvantage. When something is spoken too much, either people start taking it very lightly, or it is a half knowledge that gets into a problem and people start not taking it too seriously or in the right mode. So pneumonia can be treated as outpatient, can be require ICU admission, and if not properly and adequately treated, probably can land to a multiple of complications for the rest of the life. And that's what we are seeing with the COVID pneumonia also. So basically, pneumonia can be of different varieties. It's basically an inflammation of the lung parenchyma, which might involve the segments or the lobes or even the terminal bronchioles, depending on the part. We have viral, bacterial, and fungal. For us in ICU, all three are very critical. Commonly, the community acquired are usually bacterial. Then we have nosocomial pneumonia, which is hospital acquired. And then we have the ventilator associated pneumonia. There are bundles for it. But again, as you said, there are different definitions, different etiologies. But then the whole thing is the presentation is very subtle when you talk about ventilator associated pneumonia or a patient is on prolonged antibiotic or immunosuppression, he having an episodes of fungal pneumonia, which during COVID with the use of immunomodulators, steroids, decrease immunity. We had seen a lot of cases. And the problem with this fungal pneumonia, if diagnosed late or not adequately treated aggressively, the chances of mortality are very high considered with other types of pneumonia. So again, here the part of the treating team becomes much more important in knowing your patient, diagnosing it adequately at an early diagnosis is always that saves us the day. So here in again pneumonia, depending the most common, one more thing that we actually could face in the ICU in a patient could be an aspiration pneumonia. An elderly person or a patient with alcoholic is in withdrawal, or a CNS case suddenly develops a seizure, or as we have put a patient on NIV, he is not maintaining on NIV, failure of NIV, suddenly he becomes drowsy because of the CO2 retention, and suddenly the NIV pressure goes into raises the intragastric pressure. It might lead to an aspiration. So there are multiple issues of it. So there are all those things that could lead to aspiration pneumonitis also. So probably a watchful eye, as we were telling, one person should have actually a clear dedicated vision on what exactly is going to happen and what are the other anticipations, and making the patient side ready for your further anticipation so that there is no delay in the actual management of the patient will save the day for both us as well as the patient. Then this is one very common cause. It could be a multiple etiological things that could lead to metabolic acidosis. The simplest being diabetic ketoacidosis to a CKD patient who is on dependent dialysis, not dialyzed, or fluid overload, and then we can have the sepsis, which is again a very common thing. So there are multiple issues. Once patient lands into multi-organ dysfunction syndrome, can lead into metabolic acidosis. So basically, multiple etiology could be there. Again, importance of patient with metabolic acidosis may just come to the ICU, may appear normal. ABG also, there may be a compensated acidosis where the pH may be normal, but the bicarbonate may be deficient. So again, it's giving you the time to actually diagnose and treat it here so that the patient does not land into complication. And that is where the role of team gets important. That patient who is still looking calm, but is a compensatory acidosis, you try to evaluate the etiology behind the acidosis so that you can prevent it from landing into any other unforeseen complication. So along with acidosis, the other signs for patient might be hyperventilating. Patient may have a unpleasant breath odor. Patient may be lethargic. If he's a CKD, he may be in uremic encephalopathy. Liver patient, he may be an hepatic encephalopathy. Sometimes there may be signs of dehydration. Sometimes there may be signs of fluid overload. Okay. Sometimes there may be a concomitant LV dysfunction or a failure of the heart, hypotension. And these are the common presentations that come there, other than what I previously mentioned, sepsis or decay or the other things. So these are the common set of paradigms, because in critical care, always it is said that there are multiple causes, but you always have to go for the rare presentation of a common cause rather than going for a common presentation of a rare cause. So once you rule out this and start the basic first aid management, and the consultant arrives, the help arrives, and the definitive care is started. So probably we can prevent a moderate onset of disease to progress to MODS, right? So a moderate disease severity is much better treated than treating a patient who has landed up into MODS. Now, again, one more common thing now with the advent of ICU, closed ICUs, limited access, not properly aerated or ventilated ICUs. In all the setups, it's not possible to have sunlight coming to the ICU or a break-free time and all. So there are multiple issues. So, say, for example, suddenly a person who is just informed that he has a myocardial infarction, he himself is stressed, anxious. Upon that, he also has a pathological condition. And then no one in the ICU properly communicates with them. Family is not there. That fear of impending death dooms him. All these multiple factors actually causes him to lead into multiple etiologies of having difficulty or a shortness of breath. It could be anxiety related, it could be pathology related, and finally it just clubs in and finally makes our treatment option difficult. But again here, important is when the onset of etiology of the disease is multimodal, so should be your treatment pattern also. You take care of the anxiety, communicate properly, use drugs, give oxygen supply, calm the patient, decrease the supply demand mismatch, plan for definitive care. So Again, the more better multimodal management, comprehensive management in the earlier stage leads to better thing, especially in the, say, an elderly patient who is COPD, probably. A COPD might have frequent admissions into the ICU, but a lot of times you get a person who has not been visited the ICU, his first time visiting the ICU, RTA case, polytrauma, suddenly he lands up into an embolism or something. So the idea here is, do not always think of some pathological disease also. There is always a human touch that is missing in our care that can also lead to a cause for your difficulty in breathing or other issues, which can be easily taken care of with your proper human approach or a sympathetic approach, not exactly to sit and cajole the patient, but a proper communication to make him understand what you're doing and why you're doing. Especially such modalities becomes very easy when you put a patient on NIV. Simply you put the patient directly in the NIV leads to a lot of issues. You talk to the patient, just hold the mask with your hand, have a chat with him, put your hand on the back of the patient. Probably I'm trying to put you, there be some pressure that you'll face. This will make your breathing better. This will make you more comfortable. There will be some discomfort, but then it will slowly settle down. We're all there. Just couple of words along with your treatment. Not that you should delay your treatment, but as a multimodal strategy, the treatment option works better rather than just being affirmative. There are nothing you should hear. This is what I am the consultant and I am going to treat, without actually caring for it, could lead to a lot of unwanted discussions, unwanted arguments, and also unfruitful outcomes. So the whole team synchrony goes. That's not good for any one of us. So the idea here is, whenever you have a lot of time, you get a panic attack, patient just comes to the ER with hyperventilation. Probably you put a mask to him, you allow him to rebreathe so that he settles down. Then you try to look out for the cause. A lot of during the exams, young teenagers coming suddenly to the hospital with no prior history, sudden onset of rapid difficulty in breathing. So again, as we have been discussing, more important for us is to identify the background of the patient. What could be the most common cause that could lead to this particular thing? And then rightly identifying it, starting the first aid, maintaining the hemodynamics, maintaining the oxygen, maintaining the crash cart ready, and most important, always calling for help. Never try to do it singly. Always help is important. As a team, when you do it, you get more better results, and the team gets the confidence, and the team dynamics also develops very nicely. Now, this is one thing that we could always lead to. A lot of the ICUs, when they are overworked or the staffs or senior staff are not there, these are common things which we need to actually look into. There might be a very good message on the WhatsApp also that every Sunday in one hospital, one patient who is on ventilator dies because the cleaning IMA or the maid, just when she's cleaning, she pulls off the ventilator plug in. Right? That's the idea here, is to understand there are some very simple causes that could actually lead to a catastrophic action. Most important thing with the tracheostomy, now we have tube in tube thing, but priorly we used to only have one tube. Still, but with the tube in tube also, there could be an issue with the tracheostomy tube block, which could cause difficulty in breathing. So simple proper suctioning and identifying, more important is identifying the tube is blocked, first thing. And then probably simple proper suctioning, removing the inside tube, adding some soda bicarb, doing some ambu properly. So this might save the time for us, as well as prevent the patient from landing. Because once the patient, again, lungs gets de-recruited, the whole idea of your recruitment, tracheostomy support and other supportive treatment, probably in spite of being adequate, falls onto the negative side. Then common thing, patient had a pneumothorax, we put an ICD, someone forgets to, unclamp it, or it's on the patient bedside only, it's not hanging down, there is no water seal. So once the clamp is not removed, patient again develops a pneumo, but you presume that ICD is in place, but you have not watching it keenly, there is no column movement or the clamp has not been opened. So probably this again might lead into a patient having tachypnea in spite of your treatment. So that is where we have to see. Other things, commonly when we feel that patient is on ventilator, probably he should not have difficulty in breathing. But if the patient is fighting the ventilator, if there is any patient or ventilator asynchrony, that could also lead to a cause of difficulty in breathing or an abnormal breathing cycle. And again, another common cause of what we have been mentioning is whenever you try an NIV, it's not a comfortable situation with no proper counseling. there is chances that after counseling also you may have a compliance failure, or the interface may not be accepted to the patient, or patient is having a very severe condition where the NIV trial is getting failed. But then that should not lead to further anxiety and depression to the patient, or should not create a situation of panic and chaos that leads to again tachypnea or difficulty in breathing. So this basic idea of the lecture today is to summarize you to have an open view of what are the simple causes, not something really abnormal or rare cause of difficulty in breathing, where I say there is a patent foramen ovale, then patient has developed a shunt, Eisenbangerization has happened, now he has developed difficulty in breathing. It's a very rare cause. Let's focus on the common cause, what we usually face. And if you open our eyes, because it's always said, your eyes can only read what your mind knows. So probably if you know what could be the possible wrong in this particular patient, in this particular scenario, probably your approach will be more open, and it should work better for the team as well as for the patient, and finally for the society. So with these few points, I would like to stop the presentation here, and I would hand it over to Dr. Pankaj, so that if there are no further, if there's something that I need to repeat, something that I was not clear, I would help to clarify. And then we'll have a small session of question and answers, trying to just whatever we have discussed now, just trying to put it into an analogy and trying to see what exactly, how clinical scenarios, the way they present, right? So over to Dr. Pankaj, if there are no other questions or doubts.
Yeah, thank you so much, Dr. Aditya Kabra. That was a very concise but extensive overview of approach to a sudden patient coming with sudden breathlessness. I completely agree with you. First of all, we should have a very clear idea of why the patient is having a problem. We look at them, take the history, understand where the patient at which point of his care. And as you said, look for the common causes. There's a reason why they are called common, because they come so frequently. So first we make sure we rule them out, because invariably, most of the time, you might be looking for something very different, very remote, very exotic. But in the end, you will find out that mostly it's just a uncommon presentation of a very common cause. Yeah, thank you so much. One question from my end, Dr. Kabra, was wanted to know, because see, in the ICU, every time we say, ultrasound dekhenge, let's try with point of care ultrasound. In this case of an acute breathlessness, do you think an ultrasound, how much will a point of care ultrasound will help us in really diagnosing or an early diagnosis?
Definitely. See, ultrasound now it's called the sixth vital sign after the pain, or the new stethoscope, what they say, because the element of error is very minimized. And the most important thing here is, though the point of learning is slightly longer, but once you are well mastered it, you can pick up the subtle things. As we have been telling, most of the presentations in the ICU are very subtle. So if you can pick up in the early stage, say a patient developing a pneumothorax is different than patient developing a tension pneumothorax. A patient developing an LV dysfunction before going into fluid overload, patient having a pneumonia. So in the ICU, most important is, as you understand the patient condition, then you try to look out for the cause, an early presentation, early diagnosis, with minimal management. So basically it will be like minimal intervention, maximal output situation. Once you delay the diagnosis, then it becomes maximal intervention and minimal output. So definitely with the advent of ultrasound now it's very frequently available in most of the hospitals, if not all the hospitals. And I'm sure every hospital, even a 2-tier hospital, has an ultrasound machine. It might not be available in the ICU, but again, as a treating team, ICU team, if you can get aware of the in charges at least on the basics of ultrasound in diagnosing or making the ultrasound available, it should definitely help in a very significant, in a long-term outcome.
Definitely. I completely agree. See, ultrasound is the way to go. That will give you it's an extra window to the patient and will give you a very quick diagnosis. We always encourage our sisters also to keep using ultrasound for even simple things. Let's say suddenly the urine doesn't come and they are saying, the urine folies is blocked or urine is not coming. You can, most of the time the urine gets blocked and the bladder is distended. So in spite of clinical examination, you can still at least check the bladder wall about how much of the urine is there. You can check for the lung movements. You can check for even basic, even if not possible to look at the heart, but at least once the cardiologist or the ICU team is have a look at the heart, get an idea of what is a normal, what is abnormal. So at least you know where we are headed, and don't always depend that the consultant or somebody would be there. You are there at the bedside, and we would want the nurse herself to or himself to identify things faster. That way you become a part of the treating team, and that way you become more better in your clinical judgment. Okay, so I'll just share my screen. To Kabra, could you just unshare your
sure.
screen share, please? So what we'll do is, because as per the format of this step-in classes, we would be taking few MCQ questions which I have created. So these MCQs would be going on the same theme as the topic. We will discuss them as through go, and any questions or queries, you can talk to us, and we would want you to fully participate. It's not an exam or something where we're going to hound you or ask you cross questioning. It's just an open discussion. And once we finish maybe few questions, we'll just have a small short discussion, or any comments or queries are welcome. 1 second. So I think, is it visible?
Yeah, it's visible.
Yeah, sure. So I'll be starting few questions. So in these questions, let me start by saying, first and foremost, please read the questions carefully before answering. Most important, if any exam, that's what everybody says. Second, these are all based on today's topic. So, and most importantly, the more than one answer may be correct unless specified. Okay. Yeah. So the first question, cause of sudden breathlessness are all except. Okay. The question is, sudden breathlessness are all except. One is anaphylaxis. Second is obstructive sleep apnea. Third is sepsis, and fourth is anxiety. Okay.
Got one answer.
One answer. Any more? Good.
Yeah.
Okay. So I think most of you are going in the right direction. Yes, the answer B is correct. It's obstructive sleep apnea. Sudden breathlessness can be due to anxiety, as Dr. Kabra rightly said. Especially you see youngsters who are under a lot of stress under exams, they do come to you with kind of hyperventilation syndrome. They will come to you. They'll look like they'll be hyperventilating. Then you'll see them, their hands are shaking. You might see hypocalcemic changes. The hands is going to spasm. So these are the cases will come to you. Sepsis, yes. Sepsis, any patient coming with septic flare will come with tachypnea, tachycardia, increased breathing, and it is also part of your QSOFA scoring. Anaphylaxis, again, any antibiotic or drug where we gave, and suddenly you see that the patient is having breathing difficulty, bit of wheezing, a lot of skin wheels and all changing, then that is a very part of anaphylaxis. And then treatment, as you know, we'll have to go for aggressive or early or immediate adrenaline injection. So obstructive sleep apnea is a continuum of a disease. It usually says in during sleep or when they're under drowse. So this doesn't come as a sudden breathlessness, but it's a gradual presentation, and it's from a small mild case, it becomes a very serious condition as we move along. So correct. So next question. So the next question is, 1 second. Yeah, the symptoms and signs in addition to dyspnea, which may mean the cause is of a cardiac origin. Okay, the patient has dyspnea, but now we're thinking possibly it could be a cardiac cause. So as we said, there are more than one answers which can be correct. So again, condition for you. So options are A, vomiting, B, retrosternal pain, C, orthopnea, and D, profuse sweating. So more than one answer can be correct here. Again, I'll repeat the question. The symptoms or signs in addition to dyspnea, which may mean that it is of possibly a cardiac origin. The answers are vomiting, retrosternal pain, orthopnea, or profuse sweating. Okay, these are some good answers, B and C. Okay. Is it just B and C, or can there be more? Okay, so time's up. So right now, if you see, Dr. Kabra, can you help them out with this question?
So see, the question was, what are the symptoms in addition to dyspnea, which might mean the cause of difficulty in breathing is cardiac in origin. So again, cardiac in origin, obviously most common site we are talking is dyspnea. Again, dyspnea at rest. Now you have to understand, cough is one thing which will be more with the pulmonary, right? So yes, patient can have edema. There might be a raised JVP, which again goes in favor of cardiac origin. There might be, sometimes a patient may have a decreased urine output, which is again in terms with of cardiac origin. Now, when we talk about here, retrosternal pain can again be a cause. Say patient may have a retrosternal pain because of MI, right? So that is one thing that's here. Orthopnea is very classical of cardiac in origin. Profuse sweating again is very characteristic. The patient having MI will have profuse sweating. So all the signs could mean that the patient is having difficulty in breathing because of cardiac in origin. If patient has more of cough, okay, the JVP might be normal, the urine output is okay, and patient does not have characteristic orthopnea. That means the probable cause, not exactly definitive, the probable cause of difficulty in breathing is pulmonary in origin.
Yeah, so agreed. So in this case, if you say all options are right, if you will be safe on that, because any patient, it can present, classical presentation would be retrosternal pain or sweating, and classical pain, usually the left-sided pain of the left shoulder extending to the neck. But yes, orthopnea is another history, and sometimes you might have vomitings and lower abdominal pain, upper abdominal pain also, which can mimic or show you that it could be an inferior wall MI, and you might be missing, you might be thinking it's gastritis, but actually it could be actually due to an MI. Okay, so this was one we want to discuss. Next question. This is a true or false question. So we need to, all four options you need to check out. So in this patient, true or false regarding dyspnea. Okay, so option one, it can be a compensatory mechanism. 2, tachypnea can lead to hypercalcemia. 3, positional dyspnea is always of cardiac origin. And D, patient on non-invasive ventilation can never be breathless. Yeah, so I would want you to do A, B, C, D, T, T, or S, T, 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 F, F, or like that. If you can answer like that. So 4 options, I wanted to give it each option a T or true or false. So option A, true, option B, false. How would you want to go about it? That way. So let's go to option 1. Do you think can it be a compensatory mechanism? Okay, I think there are 2 answers here. Okay. So as we said, the first point, yes, it can be a compensatory mechanism as discussed by Dr. Kabra. Any metabolic acidosis, patient might be having, see, the body, what does it try to do? Always tries to get the pH back to its normal position. So whenever there's a metabolic acidosis, the body tries to hyperventilate, removes all the excess carbon dioxide so that you are able to bring down or maintain the pH. So for a compensation of a metabolic acidosis, it's the opposite. So this is a respiratory alkalosis which is done, and that is what it can be. So dyspnea, even let's say a patient coming with a diabetic ketoacidosis, usually you would say patient is otherwise fine, really tachypneic. He will say is going a little dyspneic, but otherwise okay. But you check his sugars are very high, and you do an ABG, the bicarbs are pretty low. So yes, and this point, is it compensating? But doesn't mean that this will continue all the time. If you don't control the primary problem, which is the high sugars, then you might create a bigger, and you might go into fatigue, and then you might even crash. Second point, tachypnea can lead to hypercalcemia. Is it true or false? Okay, good. So yes, usually tachypnea or hyperventilation syndrome patients do come with hypocalcemia. They do typical signs of hypocalcemia. They go into spasm. So these are the symptoms that will come to you, and usually we treat them as Dr. Kabra said regarding a rebreathing mask, and we do supplement their electrolytes, that is calcium, potassium, and all, so as to correct them, and we basically calm them down, give them sedatives, and that usually takes care of things. Okay. Third option, positional dyspnea is always of cardiac origin.
What one answer?
Yes. Correct. So I'll go by that. So correct. Positional dyspnea is not always of cardiac origin. Although classically we do read about paroxysmal nocturnal dyspnea, orthopnea as the classic symptoms of dyspnea. But there are other reasons like large effusions. There could be AB fistulas, as in liver patients. So wherever there's a change of position, they might cause these issues. So positional dyspnea, not always of cordation, but we try to rule them out as early as possible. Option D, this is a common thing which everybody keeps saying, patient on invasive ventilation can never be breathless. True or false? Very good. So yes, patient on invasive ventilation can never be false, because even patient on invasive ventilation, if not optimally corrected, then he will definitely have a problem, and these issues can be sorted out. So in an invasive ventilation, what happens if you have only connected the ventilator and you've just left it with some minimal settings? Patient may not be able to reach or give the proper treatment to that patient. The patient might require a higher PEEP, higher supports, but we have kept a very base settings. That could be a problem. There could be other machine-related issues. There is a tube block. There are secretions in the tube. There are water in the tube. So these things could be a reason. Yes, we will discuss about tachypnea and hypercalcemia. See, what happens here is patient coming with an acute hyperventilation syndrome. Basically, what happens here is patient comes, he's having a stress. Usually, I'll tell you an example which we face. Exam going person, young female, comes to us saying that she was reading and suddenly she feels very panicky and she comes to us in hyperventilating state. The family tried to coax her, calm her down, gave her water, nothing happens. So what happens once you create a hyperventilated state, you're creating a respiratory alkalosis. So once that respiratory alkalosis starts, you start a shift of all the electrolytes from intercellular to extracellular and vice versa. So you start decreasing, and with these movements, there is a decrease in calcium, there is a decrease in the potassium. You see that the patient is becoming very weak, he's very tachycardic. So how do you treat it? You just reverse the process, calm them down, make them rebreathe. That respiratory alkalosis part, you try to bring it normal, and then you correct all these symptoms. So in this invasive, this is what would be the answer. Okay. Fourth, as we said, next question. So which of the following is not a scoring system for dyspnea? Okay, so this is straightforward. There are no multiple. There's only single answer here. So which of the following is not? So answer options are MMRC or Modified Medical Research Council score. You have the NYHA scale, the Modified BOG scale, and the QSOFA. So which of the following is not a scoring system for breathlessness or dyspnea?
I think there's something we missed.
Okay, the answer here is QSOFA. I think there are no answers yet. So answer is QSOFA. QSOFA is mainly screening for sepsis. It is not for breathlessness. It talks about sepsis. It does have respiratory, but it does not really talk about breathlessness. It is looking breathless sepsis as a cause for breathlessness, and that could be one of the options. Okay, rest of them are all scoring systems in clinicals, which we talk about for the grading of a dyspnea. Okay. Next, question 5. Sudden tachypnea or due to poisoning or overdose are. So sudden patient coming to you with increasing breathlessness or increased tachypnea due to some form of poisoning. So options are 1, organophosphorus poisoning, B, opioid poisoning, B, C, benzodiazepine overdose, and D, carbon monoxide poisoning. So I'll repeat again: organophosphorus poisoning, opioid overdose, benzodiazepine overdose, and carbon monoxide poisoning.
But one answer.
Okay.
Another answer.
Yes. Again, as we said, with disclaimer, there can be more than one answer here, unless specified.
Yeah, I think they've got that.
Yeah. Okay, very good. The answer is A and D. Usually, because see, organophosphorus poisoning, it usually increases your cholinergic system. So your patient is having a lot of secretions, patient is under diarrhea, there has a lot of diarrhea, dehydration, and there's a lot of fluid getting collected into the lungs. And that's when the patient starts having breathlessness, difficulty in breathing, wheezing. This is what the presentation would be. Carbon monoxide poisoning, again, especially patient in a burns or any a big poisoning this happens or leak somewhere. So here what will happen? Patient will have again difficulty in breathing because it's all the carbon monoxide it gets stuck to your hemoglobin and it does not allow any other oxygen to connect attach to it, and that is where it's going to cause a problem. Other poisonings, opioid and benzodiazepine, yes, they do cause difficulty in breathing. They do cause the drop in saturations, but here they don't come with tachypnea. They usually come with a bradypnea, decreased respiratory breathing, and that is what causes them to go into a bigger problem. Question 6, regarding breathlessness, which of the following are true or false? Okay, so questions are: 1, patient have a normal SpO2 means that the patient is not having dyspnea. True or false? Okay. But it's showing normal, no? Why are you saying it's false? Okay, this is the typical which patients will feel, or the attenders might tell you. A normal SpO2 does not mean the patient got dyspnea. He might have dyspnea because the body is still compensating. He might still have other symptoms. See, patient dyspnea or the feeling of distress can be multiple things. So it need not be just an oxygenation or a cardiac problem. It can be due to other possibilities. So these are the things they have to look for. So normal SpO2 means even though he might be having a difficulty, and sometimes you might be having some additional oxygen to all these patients in ICU. And this sometimes masks the problem or sudden change in this. So you'll have to keep a close watch, even if normal SpO2 is there, but the patient is having some complaint. Don't just let it be, or is nothing, or you feel it is anxiety. No, it can be a bigger problem too, and you need to keep a close watch or need to evaluate it a little further. Okay. Next option was obstructive sleep apnea can lead to increased risk of MI. So the answer is correct. It is a true, because obstructive sleep apnea has been identified, or sleep disturbances itself has been identified as a chronic or a leading killer, or as a sleeping, or in the word sleeping killer here, that would be causing a cause of an increased MI. So especially right in these times where we work on different time shifts and a lot of stress, disturbed sleep has become a chronic big problem and an epidemic here, and that can lead to cardiac risk. Okay. C, point of care ultrasound can diagnose all forms of dyspnea. See, I think C, someone has written false. See, a point of care ultrasound can diagnose reasonably. I would say it diagnoses most forms of dyspnea, because if usually in the ICU, what do we look for? The most common causes could be a cardiac or an MI. You look for pneumonia or a pneumothorax or an effusion, or little thrombus, that is a pulmonary thromboembolism. All these things can be identified via point of care ultrasound. That is where the importance of using of a point of care ultrasound is recommended or being promoted, because all these things can quickly identify about this. Or if you know certain protocols, you can identify like the blue protocol or the rush protocol. These will help you identify these problems very quickly. Okay. And the option D being spontaneous neurothorax can lead to breathlessness. I think the last answer is true. Everyone knows any pneumothorax, once it will cause some pain, and once the air gets collected even more along the lungs, yes, it will cause some form of dyspnea. Option 7, this is again, as we said, it can be multiple answers here. So breathlessness in a postpartum lady. Postpartum, after pregnancy, she's been just delivered a baby, and now can be due to what? So options A, postpartum bleed. Option B, pulmonary thromboembolism. Option C, cardiac failure. And option D, Mendelssohn syndrome. Again, as I said, there could be more than one option could be correct here. Come on, guys, you can try. Very good.
To the A, B, no, ABC.
ABC. Good. I think we reached D also. Okay. So very good. So if you see all this is just it's a elaboration of what all the causes can be of a postpartum personal lady coming into you. So option 1, yes, postpartum bleed can cause a breathlessness, because here the hemoglobin starts dropping, your oxygen transport is getting affected, and it's going to cause acidosis, going to cause multiple problems. So yes, that will cause breathlessness to you. Very commonly, B, we look at pulmonary thromboembolism. because you're very worried about this. It's pregnancy itself is a hypercoagulable state, but you have just done come out of a surgery or of an LSCS or even a normal delivery. There is risk of bleed, but we have to keep a close watch and start prophylaxis, thromboprophylaxis very early. See, cardiac failure could be also a reason. Postpartum lady, even though she might be normal, all this is a high stress or high cardiac output state, and it might unmask a new problem like a valvular insult, or it could be lead to a completely unrelated and unfortunate events like a peripartum cardiomyopathy, which can be unmasked and which might not even present even before. And fourth is Mendelssohn syndrome. This is basically aspiration pneumonitis, which Dr. Kabra was talking about, which as we as anesthetists, our core competency, we are very worried about, where again in pregnancy, your basically your sphincter high risk of regurgitations, and any time during this time you might have any vomitings, and this might cause a pneumonitis. Need not be a pneumonia, but pneumonitis or an inflammation of the lungs. Okay, so these are the common causes. Option 8, complications associated with breathlessness include. So here again, options can be multiple. So complications associated with breathlessness include A, tachycardia, B, cardiac arrest, C, altered sensorium, and D, hypotension.
Guys, we are coming to the end of the session. I think you should understand it much more better now.
Okay, I think you can answer first. I think we are a little short of time too.
We got some answer A, B, D. You have to go back.
Okay.
8th question.
Oh, sorry. A, B, D, A, C, D, C. Okay, I'm playing with all of you guys. Come on, see, it's like these answers all are correct. All can cause, all are complications with breathlessness. Okay, so there will be tachycardia because any breathless patient is going to have the compensatory. It's going to surge the sympathetic system. You will have tachycardia and associated problems too. You don't take care of the breathlessness, worst scenario, patient might have a cardiac arrest due to that. Altered sensorium could be a reason, because either we are hyperventilating, either could be an anxiety issue, or even it could be sepsis. Sepsis itself with a change in altered sensorium and coming with breathlessness with fever, that could be allowed to do. And last is hypotension again, because it could be cardiac origin or a lung origin. Okay, I think we have a little short of time, so we'll just run through a bit. I think this is the last 2 questions. So one is reasons for breathlessness on a ventilator or all except. Okay, so we spoke about on a ventilator, patients can still have breathlessness. So what are the reasons can it be? So reasons for breathlessness are all except one is secretions in the tube, B, patient asynchrony, C, accidental disconnection, or D, the ventilator oxygen is set at 100%. Very good. So the answer here is D, because once you've set the ventilator oxygen at 100% and you know that the oxygen supply, everything is perfect and it is getting delivered, and still the patient's breathless, there have to be other reasons. And these are the above reasons that you will look at. Basically, there are a lot of secretions in the tube. The tube is you're getting blocked. Section has not been done. There might be a clot. There might be kinks somewhere. Even Edward Weiss, the tube might be clear, but there might be kinks in the tube somewhere. Patient asynchrony, patient is not sedated enough, or patient is too anxious, patient is not breathing along, or the ventilatory support which the patients require is required the assist control and you're going to control ventilation, or it could be due to a accidental disconnection. So patient, some tube somewhere disconnected, but we are not able to detect it, or there's a leak somewhere, and these all could also lead to breathlessness. Okay. Last question now in our set. So an 80-year-old bedbound patient, okay, lady, since the last 3 months, is a case of carcinoma endometrium post chemotherapy. Patient is at a nursing home. Otherwise doing fine. Now patient complains of sudden breathlessness in the last 2 hours. And this is the history that they've given, and patient is being wheeled in. So in your mind, what do you think should be the most probable cause? I will not say this is the only cause, but the most probable cause. Okay, options are A, myocardial infarction, B, sepsis, C, pulmonary thromboembolism, or D, pneumothorax. Here I would want only one answer here. Most probable.
We have got 2 answers. One person says it is C, the other person says it is B.
So I would want you to choose only one. So 80-year-old again, bedbound, last 3 months, carcinoma endometrium, post chemo, at a nursing home, otherwise well, sudden breathlessness in the last 2 hours. Very good. So okay, the option here, see, all the points are here. We're very highlighted. Elderly, again, bed bound. Again, once you hear a patient saying bed bound for a long time, you know the circulation, they may not be moving around much. There is a high risk of thrombus happening in the deep veins. Again, patient is a case of carcinoma endometrium. So there is a carcinoma component. Again, risk of a hypercoagulopathy. Post chemo, again, these drugs can cause it. And patient at nursing home. So all these where you know that, and is an elderly, so you know she's not going to be moving around much. So all these put together, the most problem, the first component could be definitely is a pulmonary thromboembolism. We need to rule it out. Yes, other causes, I agree, like sepsis, MI could be probable causes because it's an as per the age group. But yes, the classical history and the presentation goes towards a pulmonary thromboembolism. Okay, so I'm done with my question set. Any questions or any queries from your side, please let us know. And if you want us to connect with us or you want us to share any data with you, we would love to do that. Okay.
So in the final thing before we leave, again, I would like to reinforce the thing. In the ICU, go with an open mind. Look for the history, look for the subtle signs, look for what the patient is going through, what is the history, what are the signs and symptoms the patient is presenting, and what is the most common cause that could fit into this patient that could actually help you in treating the condition. So once you can diagnose it correct, your treatment is obviously correct. If you diagnose it wrong, then everything goes wrong. And one more request I would like to say, in ICUs, just by putting oxygen 10 liters, 12 liters, 14 liters, if patient is maintaining saturation, that's a false sign of security. So if you have any patient who is not actually breathing properly, difficult in breathing, there is a vein circuit available everywhere. Just hold on it. It gives you 100% oxygen and probably gives you time before the consultant comes and the definitive treatment starts. So the idea here is do not do further harm if you cannot do something correct. With these words, if there are no doubts, thank you, Dr. Pankaj, for sparing time for us. If there are no doubts, then with the permission of all, I would like to conclude the session.
Yeah, sure. So thank you so much, Dr. Kabra. Very, very good. Thank you everyone for participating and for actively answering all the questions. So any queries you would want, you can always connect to us or you can we can get back. Okay. Thank you so much. Have a pleasant evening.
Thank you.
Thank you.